we are starting our next workshop. I'm sure you will enjoy this one as well. And actually, we have been working with neurotracks for the last decade. Actually, we have a 10-year experience, so we also need to celebrate a birthday. And Dr. Eli Simon and Dr. Itamar Doniger are both the people that will present the workshop today. They will start by a short lecture to show you the application and how it will be tested. And I encourage any one of you that is interested to ask the people from the company to have a translation to your language. Because unlike the games, that many of the games without any language, a patient can practice and you can have the results without even knowing a word in a foreign language. Here we need to have some idea, or the patient needs to have some verbal or function. So I'm sure Eli and Itamar will be happy to translate to your language. And I know they are very good at it, and you can validate the translation. So Eli, please.
And thank you again for inviting me to speak at this wonderful conference. It really is a special occasion. We've been working together for 10 years. Neurotracks also has just celebrated its 15th year. So this is a pretty good occasion. I want to just tell you a little bit of the story behind Neurotracks, and then we'll dive into what the actual system is all about. I'm a clinical neurologist, originally from New York. I now live in Israel. I moved to Israel in '96 for personal reasons. And when I was in the US, I trained at Albert Einstein Neurology Department, and then did a 3-year fellowship at the NIH, thinking I was going to go into laboratory neurophysiology. And that's what I was working on. I moved here and slanted my career once passing through the movement disorder unit at Tel Aviv Medical Center into cognition. And the reason is that I realized, probably as many of you do, that when you're taking care of neurological patients, there's many times that you want standardized assessments of cognition that go much more in depth than what we have with our bedside evaluations. And it's very hard to get those assessments. The psychologists are few in number. When you can get the assessment, often it takes a long time to get the report, and it's very expensive. Even in a large academic institution like where I was practicing, it was very hard to get the attention of the neuropsychologist to obtain the necessary cognitive assessment. So that led me to think, how can we improve this situation? My other background is in biomedical engineering, so I started to think of how can we build a machine using the personal computer to do the job, not necessarily in the same way that a psychologist does it, but certainly well enough that can be done in a short period of time, very inexpensively, and in a standardized way by any doctor in the world who wants to do it. And that was the beginning of the dream that I started in 2000. So I formed this company called Neurotracks together with a neuropsychologist named Professor Avram Schweiger. We designed and built the tests that you're going to see, and we built it on the platform of a computer system that is meant to be user-friendly to the point where it could be done in a doctor's office, not necessarily in a research environment where people are more careful. So we tried to achieve something that was quite ambitious. The other thing which you're going to hear as I introduce the system more, from the beginning, I realized that there are many people who have never used computers. Especially this was true 15 years ago. Older people in particular who need the testing would be difficult to test them on a computer. So it set a bunch of challenges up, which I believe have been satisfied and proven out over the years. So what we have now is the Neurotracks computerized assessment system. Over the years, it's gone by different names. If you get on the website of neurotracks.com, you'll see the name Brain Care. That's a more modern version that's being marketed now in the United States for neurorehabilitation care. And the tests were designed with the following issues in mind. So the challenges that are available in the standard neurocognitive assessment you see here, it could take a very long time, hours, sometimes days of testing. The standardization is sometimes not as good as you would like. And there are different psychologists and clinicians who administer different tests, and it's often difficult to compare between them. What the healthcare provider needs is brief testing time, under an hour, standardized methods, objectivity, and easy to understand intuitive tests. NeuroTracks has now been around since 2000. There are now close to 120 peer-reviewed publications in the medical literature that attest to the validity as well as the practical use in many different conditions. The use in MS is important, but it was actually not the original intention. NeuroTracks was developed to help identify MCI and early dementia and the different types of dementia in the elderly. It was then applied in children and ADHD. It was applied in psychiatry, primary psychiatric problems, as well as psychiatric accompaniments of neurologic disease. And then it's been also used in the general neuroscience literature to evaluate cognition according to different interests of various investigators. So we're very open to collaborations with researchers, and I welcome all of you to think about how this tool could be used in your own research and to approach myself and Dr. Doniger to talk about possible collaboration. So what is NeuroTracks? NeuroTracks is computerized testing. You're going to be seeing these tests in a little bit in the hands-on. Okay, it's easy to use. There are different batteries of tests that are put together to try to minimize testing time where that's possible. But even the longer batteries take about 60 minutes, not longer. So it's a lot shorter than the standard neuropsychological evaluations. There are large, clear pictures, text that makes it very easy to understand. And the patient responds with intuitive devices. In particular, the patient responds using the mouse by pressing the left and the right mouse button, not having to move the cursor or do anything complicated. Again, keeping in mind that we try to design this so that it's as simple as possible even for people who have no computer experience. Another important feature of the testing is called adaptive testing. Now, what we decided was that it's important to make the subjects comfortable when they're doing the test. So if you have a low-performing person, you don't want them to get frustrated by parts of a test that are much too difficult for them. So the way the tests are built, they gradually build up in levels of difficulty. They start easier and they become more and more difficult. If someone does poorly on the easier levels of the test, then the test is terminated and the score is adjusted. So that results in a less frustrated patient and a shorter testing time. The battery of tests is preceded by what we call the computer orientation. This essentially gives the patient an idea of the type of input that they're going to need to do during the actual tests. They're trained to press the left mouse button, press the right mouse button, press 1, 2, and 3. It all seems fairly elementary to those of us who use computers all the time. But for people who have not used computers, this may be difficult. We want to make sure that they're able to do it. And we also make sure that the person has adequate color discrimination for the two tests that require color discrimination. They're able to see the letters in order to respond and read the instructions adequately. If they do not respond adequately on any section of the computer orientation, then the tests that are dependent upon those skills are automatically skipped so that the end result is valid testing data. You don't have to worry that my patient really didn't have adequate vision, because that part of the test would be skipped automatically based upon their performance on the computer orientation. Another feature to make sure that this results in good data is a practice session that occurs before every test. You'll be seeing this in your demos. Every test has a set of instructions. Those instructions are shown. The patient can read them. It's in simple language. After that, they actually perform what looks like the real test, but it's not actually the real test. It's usually much simpler, and sometimes it just is in the place to teach them the mechanics of doing the test. If they're not adequately able to master the mechanics of the test, or they don't understand the instructions, they will fail the practice test, and then they're given another practice test. If they fail that one as well, then the test is skipped, and that shows up on the results. So that, again, you get valid data at the end. A word about timed and non-timed tests. In the world of cognitive testing, it's very important to keep in mind a trade-off between speed and accuracy, so that when the patient is put under stress to respond quickly during a particular task, their accuracy may suffer because of that stress. That's fine if you're trying to test executive function or information processing speed or attention, because there the timed measurement is very important to making an assessment of those faculties. But if you're testing a cognitive function that requires something that is not time dependent, such as memory or visual spatial processing or language skills, then on purpose our tests are not under pressure of time. So you'll notice as you go through the demo that some of the tests tell you to respond as fast as possible, and some of the tests do not tell you that instruction. The actual interface with the system is fairly simple. It's usually your staff, either clinical staff or research staff, who will actually be getting onto the web portal. But there's a website that NeuroTrax maintains that is available to the public, but there's also a section that you can sign in with your login and get into this NeuroTrax web portal. The system will recognize you. It'll show you only the data from your patients so that you can review it. It will allow you to order new testing sessions and to choose batteries or testing languages that are available, so that the interface is very intuitive and easy. The other part of the system is the desktop application. So the tests are actually run on the local personal computer, not over the web, so that the resulting reaction times can be relied upon, rather than having to worry about the transmission times over the internet. So there's a program that's downloaded once onto each personal computer that is used as a testing computer, which can be as many as you like. If your clinic uses 5 different rooms for testing, you can download the same program on all 5 computers. You download the order for that testing session on that particular patient for that particular day. Those instructions get downloaded very easily to the app that is sitting on the personal computer. Then the computer does not need to be attached to the internet during the testing. You can take the laptop out to the field, to a person's home, to a nursing home, or wherever that person may be, to actually do the testing and collect the data. So it provides for extra flexibility. The basic technical requirements is a standard Windows PC. Any modern personal computer is sufficiently strong and fast to be able to run the NeuroTrax tests. But more than that, it's possible that you had a computer that was fast enough and was good enough, but now maybe somebody put a lot of programs on the computer or loaded it up with a lot of data so that the hard drive is full. Well, we have a program that runs in the background all the time to make sure that the hardware is adequate and fast enough to be able to result in reliable data. As I mentioned, there's a requirement for an internet connection for uploading and downloading the data, but not actually for running the test. It's important to maintain adequate testing conditions. This is really for the validity of the output, not so much as a technical requirement, but to make sure that the person taking the test can concentrate on doing the test and isn't distracted by a lot of noise is an important thing. It's recommended that there's a dedicated PC to do the testing, simply that there's no one other than the testing personnel loading up the computer with games which may have viruses and things like that. Now we're going to show a short video that Dr. Doniger prepared, which is going to describe the actual tests one by one.
Test. The patient's task is to use the keyboard number pad to select the word that had been paired with the word shown at the top of the screen. As you can see, the practice is rather simple. If the patient passes the practice, he or she will continue on to the actual test, in which a series of 10 word pairs is presented, followed by a multiple choice recognition test. If the patient attains a perfect score, the test will conclude and the battery will move on to the next test. If the patient cannot remember all the word pairs correctly, the 10 word pairs will be presented again, followed once again by a multiple choice recognition test. This study test sequence repeats up to 4 times, depending upon the patient's accuracy. If the patient obtains either perfect accuracy or an extremely low accuracy, the test will automatically conclude and the patient will be scored accordingly. In the case of perfect accuracy, there is no need to continue presenting the word pairs, as the patient has already learned them. And in the case of extremely low accuracy, the battery has already collected enough information regarding the patient's level of performance, and there is no need to frustrate the patient with additional immediate repetitions. After 2 intervening tests, there is 1 more delayed repetition of the multiple choice recognition test for the word pairs. The battery records accuracy for the immediate and delayed repetitions of the recognition test. The nonverbal memory test is a test of memory for pictorial information. Pictures are presented, followed by a multiple choice recognition test for the pictures. On each practice session trial, a picture is presented, followed by a simple recognition test. The patient uses the keyboard number pad to select the previously shown picture from among the options. All response options depict the identical object, but facing different directions, so the task is actually to remember the direction of the object. If the patient passes the practice, he or she will continue on to the actual test, in which a set of 8 pictures is presented for 20 seconds, followed by a multiple choice recognition test. The adaptive test design is the same as for the verbal memory test. If the patient attains a perfect score, the test will conclude and the battery will move on to the next test. If the patient cannot remember all the pictures correctly, the 8 pictures will be shown again, followed once again by a multiple choice recognition test. This study test sequence repeats up to 4 times, depending upon the patient's accuracy. If the patient obtains either perfect accuracy or extremely low accuracy, the test will automatically conclude, and the patient will be scored accordingly. In the case of perfect accuracy, there is no need to continue showing the set of pictures, as the patient has already learned them. And in the case of extremely low accuracy, the battery has already collected enough information regarding the patient's level of performance, and there is no need to frustrate the patient with additional immediate repetitions. After 2 intervening tests, there is one more delayed repetition of the multiple choice recognition test for the pictures. The battery records accuracy for the immediate and delayed repetitions of the recognition test. The go-no-go test is a continuous performance task, or CPT, measuring attention and executive function. A series of colored boxes is shown at pseudo-random intervals, and the patient's task is to press one of the mouse buttons as rapidly as possible whenever a box appears, but not to press when the box is red. During the practice session, the battery gives feedback for incorrect responses. If the patient passes the practice, he or she will continue on to the actual test, which consists of a longer series of trials. The battery records accuracy, average response time, and response time standard deviation. Separate scores are given for errors of commission and errors of omission. An error of commission, that is, when the patient mistakenly responded to a red box, is related to lack of inhibition, whereas an error of omission, when the patient failed to respond to a box of some other color, is related to inattention. An expanded version of the go-no-go test is available, in which there are 3 additional test levels, each of which varies a particular dimension: interstimulus interval, number of catch trials, that is, red box trials, and presence of distractors. Scores are given for each test level separately, as well as for the entire test. The Stroop interference test is based upon the classic Stroop effect, whereby processing a color word is more difficult when there is a conflict between the color of the letters and the meaning of the word, as compared to when there is no conflict. For example, if I present the word red in blue letters, it is more difficult to report the color of the letters than if I present the word red in red letters. This Stroop effect is a measure of executive function, particularly in terms of the ability to inhibit the interfering influence of the meaning of the word. The NeuroTrack's Stroop test consists of 3 levels. In the first 2 test levels, there is no interference between letter color and word meaning. Then, in the 3rd and final test level, there is interference. First, a practice session familiarizes the patient with a type of task. An instruction appears at the top of the screen with 2 colored boxes below, one on the right and the other on the left. The task is to read the instruction and then press the right mouse button for the right colored box, or the left button for the left colored box, as rapidly as possible, depending upon the instruction. If the patient passes this practice session, he or she will transition into the first level of the actual test, where the task is to press the right or left mouse button depending upon the letter color of common non-color words, like computer. In the second level of the actual test, the task is to press the right or left mouse button depending upon the meaning of color words like red, all presented in white letters. Then, an additional practice session introduces the patient to the Stroop effect and trains him or her to respond according to the color of the letters, despite the conflicting meaning of the word. If the patient passes, he or she moves into the actual test level, where the psychometrics is identical to the previous test levels, but there is interference between letter color and word meaning, with the task to respond according to the letter color. The battery records accuracy, average response time, and response time standard deviation for each test level. The catch game is a test of psychomotor function related to both executive function and motor skills. The test is similar to an early computer game. The patient places his or her dominant hand on the mouse and presses the left or right mouse button to move the green paddle at the bottom of the screen into the path of the falling white object. First, there is a practice session to familiarize the patient with the task. If the patient passes the practice, he or she will transition into the actual test. The test is adaptive in that the object falls progressively faster, provided that the patient is performing well. Otherwise, the test will automatically conclude and the patient will be scored accordingly. The battery records accuracy, average time to make the first move, and standard deviation of time to make first move. A separate score is given for average number of direction changes per trial, a measure related to decision making. The staged information processing speed test is a test of the ability to rapidly process information and parametrically varies two dimensions, cognitive load and stimulus presentation rate. The test consists of 3 blocks. In the first block, single digits are shown. In the second block, 2-digit arithmetic problems are shown. And in the third block, 3-digit arithmetic problems are shown. Each block consists of 3 test levels corresponding to slow, medium, and fast presentation rate. All patients complete the slow level within each block. Then, if the patient's accuracy on the slow level is sufficiently high, the battery will move on to the medium level. And if the patient's accuracy is high enough on the medium level, the battery will move on to the fast level. The patient will be scored accordingly for any levels skipped due to poor performance. Throughout the test, the patient's task is to press either the left mouse button or the right mouse button as rapidly as possible, depending upon the single digit or the solution to the arithmetic problem. If the single digit or solution is 4 or less, the patient presses the left mouse button. Conversely, if the single digit or solution is greater than 4, the patient presses the right mouse button. The parametric test design allows controlled comparison of the effects of cognitive load, stimulus presentation rate, and their interaction. The battery records accuracy, average response time, and response time standard deviation for each test level. The visual spatial processing test is a test of visual spatial perception. During this test, a computer-generated scene containing a red pillar is shown at the top of the screen. The patient's task is to choose the view of the scene that he or she would see when standing at the location of the red pillar. During the practice session, the battery gives feedback. If the patient passes the practice, he or she will continue on to the actual test, which consists of a longer series of progressively more difficult trials. The battery records accuracy on this test. The verbal function test is a test of language that measures rhyming and naming ability. On each trial, a picture of an object is shown, followed by a set of response options. In the first part of the test, the patient uses the keyboard number pad to select the word that rhymes with the name of the picture. In the second part, the patient selects the name of the picture. There is a brief practice session prior to the rhyming level to familiarize the patient with the task. If the patient passes the practice, he or she will continue on to the actual test. The battery records accuracy for rhyming and naming, or matching, portions. The finger tapping test is a test of fine motor skills. The patient places his or her dominant hand on the mouse and presses one mouse button as rapidly as possible while the white rectangle fills with red. This task is repeated twice. The battery records average intertap interval and intertap interval standard deviation. The problem-solving test is a test of nonverbal analytical problem-solving ability. During this test, pictorial puzzles of gradually increasing difficulty are presented. Each puzzle consists of a 2x2 matrix containing 3 black and white geometric figures with a certain spatial relationship among them, and a missing figure. The patient's task is to choose the best fit for the 4th missing figure from among 6 possible alternatives. On this test, the practice session is when all the shapes in the puzzle are identical, and the actual test begins when the shapes are different. If the patient passes the practice, he or she will continue on to the actual test. Solving the puzzles requires problem-solving and abstraction abilities. The test is adaptive, and progressively more difficult puzzles are presented, provided that the patient is performing well. Otherwise, the test will automatically conclude and the patient will be scored accordingly. The battery records accuracy for this test.
Okay, I'm going to just walk you through the actual report that the computer generates within seconds after the data are uploaded following a testing session. This report is designed for clinical use so that each patient can be evaluated immediately. If data are being generated for research purposes, then besides for this report, the investigator will also receive a file ready for statistical analysis with all of the study data. What you see here in the beginning of the report, right up front, is a graph that contains a summary of all of the cognitive domains that were tested across the testing profile. And it's useful to see which cognitive domains are higher and which are lower, because they're all mapped onto a standard scale. The scale is adjusted automatically by the computer by comparing the patient's actual testing results to a database that contains data from healthy individuals of the same educational and age level of that patient. So that everybody at the end is on the same scale. All the testing domains are on the same scale, where a score of 100 is equal to the mean for the reference population, and 15 points is equal to 1 standard deviation. So here it's shown graphically, and then below you see these index scores that are composed of different parameters from tests that tap into the same cognitive domain, so that you can get a quick summary of how the patient fared across a range of cognitive domains. What you see in this section of the report is the score mapped onto a graph for that particular testing session, but also the same score relative to prior testing sessions. So with a very quick glance, you're able to see how the score has changed. But you see it for each individual cognitive domain, so that some domains might have improved, some domains might have worsened. You can see all of that very easily using the graphical presentation. Here is a table that shows the same data that was just shown on the graph, but adds the components that were contributing to each cognitive domain. So you can see each individual score. On the back part of the test, on the back part of the report is what's called the detailed test results. And this, for those who are really interested, contains all of the data for all of the tests, both the raw scores and the standardized normalized scores for every testing session. So that if you have neuropsychologists on your staff, or if you want to look at these numbers yourself, all of the numbers are here to the standards that are available for any type of neuropsychological evaluation. Finally, I want to show you that this report also contains the results for other scales that might be administered. So for example, in this report, there's the geriatric depression scale and the Zung anxiety scale. Those scales are available as part of the testing battery, and they could be administered. Those results then would become part of the testing record and would show up on the report. So with that, I'm going to turn over the presentation to Dr. Doniger, and he is going to present to you research data. And as I mentioned, Dr. Doniger is the research guru behind NeuroTrax. He knows all the data and coordinates all of the research studies. So if there's interest in research, please talk to Dr. Doniger.
Okay. Okay, so just a brief overview of some of the science that underlies NeuroTrax. This is what I'll talk about. Okay, different types of validity and reliability, and with a particular focus on MS. All right, first of all, it's important to demonstrate that the cognitive domains that NeuroTrax measures are measuring the same constructs as paper-based tests, traditional neuropsychological tests. And And as you can see in the top portion of the slide, in a variety of cohorts that has been demonstrated, good correlation between the NeuroTrax tests and the paper-based tests of the corresponding cognitive domains, and also other computerized tests at the bottom of the slide. Here are some representative correlations. So you can see, for example, the NeuroTrax verbal memory test correlates with the Hopkins verbal learning test, a paper-based test of verbal memory, the correlation coefficient of 0.72, and so on. This is data from a study conducted by Anat here at the MS Center in Sheba. It was conducted in 2007, correlation between ROUSE NSBMS and NeuroTrax in multiple sclerosis patients. And as you can see here, the NeuroTrax scores in the various domains did correlate with the NSBMS scores in the corresponding domain. This is data from a clinical sample from a neurologist in the New York area with a large sample of MS patients. And you can see the nice linear relationship between NeuroTrax global cognitive score and simple digit modalities classification. Simple digit modalities is often used as a screen for MS. This is data from Efrat Sasson, who was a student of Yaniv Asaf, who spoke this morning. Factor analysis of some of the NeuroTrax outcomes showing how on the first factor, NeuroTrax go, no-go, and Stroop scores hang together in an executive function factor. The second factor scores from the nonverbal memory and the verbal memory tests from NeuroTrax hang together on a memory factor. And the third factor, information processing. So all of this points to the construct validity of the NeuroTrax scores. Here you have data from US Navy divers who were tested and retested with NeuroTrax, demonstrating test-retest reliability, so rather high correlations. We do have 3 alternate forms to minimize practice effects. You can see that the correlations among the pairs of forms here are all rather high. This is some more test-retest data. The notable portion of the slide is on the right, 6 cancer patients, very high correlations. It's just 6 patients, but still very impressive. Here's data from the Achiron 2007 study. This is demonstrating the discriminant validity of the NeuroTrax tests for MS. So you can see 58 MS patients, 71 cognitively healthy, and significant differences for all of the NeuroTrax index scores with the exception of visual spatial and verbal function. On the right, you can appreciate the value of precise response time measurement. This is data from the Staged Information Processing Speed Test, showing that if we look at accuracy alone in the top panel, there's no difference between the MS patients and the healthy controls. But if we look at the response time, which we measure rather on the order of milliseconds, there are significant differences between the groups, and also for the standard deviation of response time in the bottom panel. This is data that you've already seen this morning. It's from Anat's 2013 paper looking at the various MS phenotypes. It's just emphasizing here how the secondary progressive have a particularly long disease duration relative to the other phenotypes. And if we look at the cognitive function with the MS, rather with the NeuroTrax scores, you can see that indeed the NeuroTrax scores for the secondary progressive group are significantly lower than they are in the other groups. Here's data from that neurologist, Mark Gudesblatt, that I showed you earlier, from whom I showed you data earlier. This is EDSS, just showing how NeuroTrax scores track with EDSS. And here is the MSSS, Multiple Sclerosis Severity Score, which takes disease duration into account as well. Again, showing that if that we can discriminate, or NeuroTrax can discriminate very nicely when you look at the number of domains that have more than one standard deviation below average. This is disease duration, showing how disease duration tracks. This is data, again, from the Achiron 2013 paper, and as was stated this morning, the most interesting piece of these curves is probably the initial piece between 1 and 5 years of disease duration, when there was not yet significant impairment. If we look at the two domains that were most impaired in this study, information processing and executive function, we can see that the slope of that initial portion of the curve is different, so that it's much more shallow for the information processing as compared to the executive function. And this just points up the value of a measure like NeuroTrax with multiple domains, precise measurement. Here is some data, retrospective clinical data from MS patients, relapsing remitting MS patients who were treated with Tysabri, looking at when they had received 0 to 3 infusions versus at least 9 infusions, and showing significant differences on NeuroTrax memory and verbal function index scores. Here, if we look at the tests that contribute to the memory index, we can see that the memory difference is driven by the verbal memory test, but not by the nonverbal. This is data from the Sheba MS Center from a student named Lior Orbach, showing that in patients who were on Tysabri for 2 years, in relapsing remitting MS patients, there was no difference in cognitive function, and there was also no difference in cortical thickness. This is employment data showing the NeuroTrax tracks with employment. You can look on the right and see the SDMT, the symbol digit modalities test. You can see the effect size. This is Cohen's D. So you can see that the NeuroTrax executive function and global cognitive score, for example, have a larger effect size than does the traditional SDMT. And the catch game total score, the catch game is that test with the falling object, actually has the largest effect size of all of those. Okay, some other data showing differences between fallers and non-fallers in MS from Sheba. Just going to run through these. Correlations with walking and fear of falls. This is correlations with sleep measures in MS patients who report fatigue or sleepiness. This is correlation with visual evoked potential latency in MS. And finally, this is also a study from Sheba where MS patients showed differences to controls in various regions, but the only one of these regions that correlated with NeuroTrax cognitive function in multiple domains, as listed there, was the left superior temporal gyrus. So that's the type of information that you can get with NeuroTrax. So at this point, I would like to direct your attention to the computer monitors in front of you, and you should have the NeuroTrax desktop app open on the screen. I'd like you to click on the third row where it says Comprehensive Testing Suite. Okay. And you should choose your primary language if it's available. If your primary language is English, then that would be at the top. Other languages are down below. And we'll walk around and answer any questions you've got as you go through this demonstration. As Eli said, we're very interested in collaborations, so please don't hesitate to ask us about potential collaboration. And you're welcome to take the flyers that are on your tables. Good luck.
You get the same. You'd have to just validate. It doesn't mean it would be as bad.
Geil. Vielleicht ist das schon der Beste und du weißt es nicht, weil es dich immer so lobt.
Ganz sicher. In our test, we used large letters and clear pictures. However, you didn't think
Nu מתקדם. מה הם רצו? נו, ואז? לא עקבתי. אוקיי.
Der ist bei viel frustriert und hat genau dasselbe wie derjenige, den wir bis auf 80 geschafft haben. Den lässt man dann raus und der kriegt dann den Wert von dem anderen, der das dann 80 Mal gemacht hat. Also das wäre
Now you will be shown 8.
would be the code that we open long table.
Immer gefunden. Letztes Letzte hat so also wieder plötzlich so. Was wir aber so mitgenommen haben, dass ich den Spieler können Sie in dem Fall gar nicht so. Okay, das können wir vorstellen.
Select your right hand. With your right hand.
Dreapta.
Nu, stai fiecare și are formularul în memorie.
זהו, הוא סופר נראה לי כאן טועים, ויש בטח כאן. קצת התעמלות לאצבע.
Care mâna mai bună. Da.
Continuă.
Iona Mihalakovna.
Puteți să le
No, non te ne
fiu.